Welcome to yet another session on IRACON-TV. We have eminent professor in scleroderma, Professor Allanore from Paris. He's professor of rheumatology with special interest in scleroderma. So, Professor Yannick, how do you find the academic acumen of IRACON?
First of all, I'm very happy to be here, and it's really a very stimulating meeting. I think the interactions are particularly good because the training of the doctors is clearly of high level, and we have very good questions during the session, after the session, during the coffee break. So I think it's really a success, and it's very stimulating to interact so deeply with the Indian doctors. And I really appreciate very much.
Thank you. What is the architecture of scleroderma clinic at Paris? How do you run with how many?
So, the standard for us is at least a full assessment during a one-day hospitalization for each patient, during which we will assess heart, lung, general manifestation, questionnaire of quality of life. So this is the minimum of follow-up, 1 or 2 outpatient visits, and 1 annual one-day hospitalization to cover all the aspects of the disease. And of course, for the patients who are more severe, we have inpatient hospitalization for administration of infusion, prostanoids, or biologics that can also be used. So this is the standard of the follow-up, and it is also based in regarding our participation to the USTAR database, for which we register annually a global assessment of the patient every year to provide skin, lung, joint measurement every year to do some clinical research for these patients.
And who's there in your team?
So we are only rheumatologists in our team. However, we interact with pulmonologists, nephrologists, dermatologists. And I think regarding what we have been discussing this morning, interstitial lung disease, to organize multidisciplinary discussion is very important, because we talked this morning about the key aspect of determining whether a patient is progressing or not progressing regarding ILD. And to do so, we need the symptoms, we need the radiologist for HRCT, we need the physiologist and the pulmonologist for pulmonary functional test, and then the global assessment and the integration of all the data by the rheumatologist. So the patients are mainly treated by the rheumatologist, but with the help and with a strong interaction with the other specialties.
So do you still see the late disease of scleroderma because you are picking up the disease quite early?
Yeah, you're absolutely right. This is the direction we have to follow. We have now some criteria for diagnosing the patient early and to identify very early predictive markers. So this is what we have to do. And to do so, Raynaud's phenomenon is probably a key marker of the very beginning of the disease. And we are organizing some Raynaud's clinics. And when a patient has Raynaud's phenomenon, autoantibodies, abnormal capillaroscopy, then he will be fully evaluated for having scleroderma or being at risk of scleroderma in order to adapt to management as early as possible. This is absolutely mandatory. This is the direction in any inflammatory or autoimmune rheumatic diseases, RA, ankylosing spondylitis, and so on. And this is the same for scleroderma. We have to capture the patient early and to offer them the best management as early as possible.
So can you elaborate more how to predict that this Raynaud is going to progress into systemic sclerosis without any at present?
We talked yesterday about the VDOS projects and the VDOS criteria. So I think that today we have robust data to show what, and when a patient is attending a clinical department because of Raynaud's phenomenon, it means probably that it's not all the Raynaud's patient, but Raynaud's of recent onset with recent progression, more severe Raynaud's. And if then you are able to identify abnormal capillaroscopy or specific scleroderma autoantibodies, there is a very, very high risk, more than 70%, that the patient will develop in the next 5 to 10 years an overt systemic sclerosis. And therefore, you have to start the treatment as early as possible.
Professor, what is the breakthrough in the genetic understanding of scleroderma? Is there any new understanding, new genes discovered?
So the genetic data are very interesting, and so far, according to all the investigations that have been done regarding genome-wide association studies and family studies, are showing that mainly the susceptibility factors belong to the immune pathway. And most of the time, this gene and these variants are not specific of scleroderma, and they are shared with lupus, rheumatoid arthritis, and so on. So it means that we are identifying a set of variants that are promoting a risk of abnormal immune response that, in the context of environmental factors, may induce systemic sclerosis. So we can see that as something quite disappointed, but because there is no scleroderma gene, but at the same time, it is highlighting the role of the immune system, and it is further supporting that we have to be active against the overactivation of the immune system in order to temper systemic sclerosis.
Doctor, do you advocate screening for ILD in limited scleroderma?
It's a good question, and I think there is a professional agreement that any patient with systemic sclerosis, whatever he has a diffuse or limited cutaneous subset, should be investigated at the time of the first visit by HRCT in order to determine whether or not there is already interstitial lung disease. Thereafter, the follow-up would be more clinically or PFT oriented, but you are right, the risk of ILD is lower in the limited cutaneous subset, particularly in the patient with anti-centromere antibodies, but we know that the patient with the limited cutaneous subset and anti-topoisomerase are at risk of ILD and progressive ILD. So the cutaneous subset alone is not sufficient to decide whether you want to screen or not your patient. So I think the agreement is to screen everywhere and more carefully with a more close follow-up of the patient with the diffuse or anti-topo antibodies.
Since this is a heterogeneous disease, when you have only the skin involvement without pulmonary hypertension or ILD, do you offer any treatment for them?
Yeah, this is important because skin is leading to disability because of the skin by itself, but it is also a marker of risk of organ involvement. So we use skin involvement as a surrogate of more severe. So if you are in front of a patient with diffuse cutaneous subset, even if the patient does not have major organ involvement yet, is at risk of developing major organ involvement. So you have to introduce a treatment. Usually the treatment is mycophenolate mofetil, methotrexate as a first-line treatment, and then you monitor the patient regarding the potential development of other manifestation of the disease. But the answer is yes. In front of diffuse cutaneous systemic sclerosis, you have to start a treatment, again, to temper the immune system, to try to prevent major organ involvement.
That is a combination treatment, not the monotherapy with methotrexate or mycophenolate.
So usually we do not combine these two synthetic immunosuppressants, but after the start of one of the two, methotrexate is more used in case of associated joint involvement, muscular involvement, and when it is more purely skin involvement, it is more mycophenolate. But if you identify that 3 to 6 months later, your patient is still progressing, has an inflammatory background, inflammatory marker, then you will add to the initial synthetic immunosuppressant another treatment that is more and more biologic treatment. And the two treatments that are really emerging are rituximab and tocilizumab.
Okay. Now, about pulmonary hypertension, where do you place IRACON in the treatment stratification of pulmonary hypertension? Is it to be given early or late in the disease?
Yeah, I think we have learned a lot from the story about pulmonary arterial hypertension because we usually capture our patient before they develop PH. Therefore, if we screen them carefully, we are able to identify PH early in this patient. When you show that GLCO is going down, that the systemic pulmonary arterial pressure is increasing on echo, then it's time to perform right heart catheterization and look if the patient has pH, yes or no, and which subset of pH. And once pH is confined, clearly the direction is to combine treatment with upfront combination therapy. And this is a lesson for us. This is telling us that in scleroderma, which is a severe disease, a complex disease, we have improved the vascular outcome once we have reached the point of combination therapy. And it is also probably true for the fibrotic component of the disease, where we will have, we have and we will have in the future to combine therapies to be really efficient against the progression of the disease.
So what about mild pH? Do you still give combination dual therapy in mild pH, or you go with
Yeah, scleroderma pH has poor outcome as compared to the other type of pulmonary arterial hypertension, the idiopathic form or the other associated disease. So clearly, we will start with upfront combination therapy in a majority of the patient. In only a small subset, as you were raising, with minimal pressure, without any heart consequence, maybe a monotherapy may be discussed. But the general recommendation is to start upfront combination therapy and use, the variables and the criteria to be sure that the patient are at low risk of progression of pH, because this is also well established in this condition.
hematopoietic stem cell transplantation is creating a lot of interest in people, and many have confusion whether it works and at what stage it works. So what is your take on that?
Yeah, the data are showing that the stem cell transplantation following intensive immunosuppression may be beneficial, but the safety is not very good. And the criteria to select the patient are not very well established. And I think because we are making some progresses in the other management of the disease, the part of the patient that may benefit from this treatment is really reducing. And this has been shown during the Congress, the recent UK data that compared the combination of rituximab and MMF versus stem cell transplantation showed almost similar outcomes, but clearly the better safety profile of the association of MMF and rituximab. And I think it will be the direction. Regarding stem cell transplantation, I think the future is more regarding CAR T cells, because again, it has been shown this morning during the presentation, we have few cases in which we have seen that profound targeting of B cells is helpful in the context of systemic sclerosis. And there are 2 clinical trials that are about to start to investigate CD19 CAR T cell therapy, which is very stimulating and will probably provide some very, very interesting results and hopefully a better improvement regarding the outcomes of the scleroderma patients.
The question about tocilizumab, in what domain it works and in what domain it does not work, out of skin, lung, and pulmonary artery?
Yeah, you're right. Tocilizumab was very well investigated in the context of scleroderma with a phase 2 and then a phase 3 clinical trial. It was investigated without any background immunosuppressant, and the studies well demonstrated that there was a trend of benefit for skin, but not with a high effect size. No real benefit regarding the functioning of the patient, and in that part it is somehow disappointing. However, what I've been seen in the clinical trial is a strong preservation of the lung function in the patient with inflammatory profile, where we have seen that the placebo arm is really deteriorating for lung, while the patient receiving tocilizumab are protected against interstitial lung disease progression. And this is very interesting. You know that it has led to the labeling of tocilizumab in the context of SSc-ILD, and it's good to have a drug available to treat our patients.
You're working a lot in the research of scleroderma. So what is the future? What is the future therapies coming which will offer some hope to the refractory patients?
So actually, there are a lot of clinical trials looking at some other antifibrotic, in addition to what has been shown with nintedanib, which is already a great achievement, but some additional antifibrotic may come. Immunosuppressants and targeted immunosuppressants are more and more into development. We know that interferon is going to be targeted Some other B-cell therapy are going to be investigated, so we will have a lot of data. And I think at the end, we will get with more than a single agent being efficient, allowing to work on combination therapy. Because for a so complex and heterogeneous disease, I don't think we will find a single pathway to explain the progression of the disease, but we will have to combine different treatments. So we will have to work on the sequential use of the various treatments, but I think it will be the direction. And hopefully, in the next years, we will get a better control of the disease in our patients.
We would love to hear next year from you, learn from you. Thanks from the bottom of my heart for giving this interview and coming to the IRACON. Thank you. Thank you, Professor Allanore.
Thank you very much again for the invitation.